All right. Good morning, everyone. My name is Alissa Guarneri. I'm a pediatric endocrinologist at UPMC Children's Hospital of Pittsburgh. This morning, I'll be discussing our quality improvement project on assessing health literacy in pediatric type 2 diabetes. And this great work was done as part of a collaboration of a multidisciplinary team. Pediatric type 2 diabetes, as we know, is a very complex disease with increasing prevalence. And despite treatment advancements, the overall quality of care remains suboptimal. And one of the most important factors contributing to this is health literacy. Health literacy is defined as a person's ability to obtain, process, and understand health information. And we know from adult studies that low health literacy directly influences poor self-management behaviors, low treatment adherence, and poor glycemic control. In pediatrics, that extends to not only the patient, but also their caregiver. And low health literacy is linked to low technology adoption, as well as increased risk of complications. And recent studies have shown that as much as 8% of caregivers of pediatric diabetes patients have low health literacy. Now, the American Diabetes Association recommends using validated, age-appropriate health literacy tools in pediatric diabetes patients, but unfortunately, no diabetes-specific instrument exists, and thus our project was created. So here at Children's Hospital Pittsburgh, we manage approximately 140 patients with type 2 diabetes. We average approximately 20 new diagnoses each year. Average age at diagnosis is between 12 and 13 years, and most of these patients have an elevated BMI. The average hemoglobin A1C at diagnosis is just over 9%. We also face challenges with social determinants of health, and where up to half of our patients identify as non-white or non-Caucasian. Most of them are publicly insured. Some of them have no insurance, and we have a no-show or cancel rate approaching 30%. When looking at the location of education at diagnosis, patients who present with a hemoglobin A1C of less than 8.5%, as you can see in the bar chart on the left, most of them receive outpatient education. And this is in pretty stark contrast to our patients who are diagnosed with an A1C at or above 8.5%, who are primarily admitted for inpatient education, and 100% of whom are started on insulin. And so to better understand our patient population's health literacy, our team did a deep dive at the literature to assess which validated health literacy tools existed and quickly realized that there are none. And so our multidisciplinary team sat down and we created a brief, less than 10 question survey that was aimed at not only our youth with type 2 diabetes, but also their caregivers. This survey assessed understanding of diagnosis, treatment, complication monitoring, and factors that impact blood glucose. We had a goal to gain input from 15% of our total patient population. And so for our first PDSA cycle, we targeted administration of the survey to patients seen within our main children's hospital clinic. We were able to receive 17 patient and 14 caregiver surveys, or just over 12% of our patient population. And so in order to get closer to our initial goal in PDSA2, we expanded that administration to our satellite clinics, and where we were able to reach that goal of 15% of our patient population. And so things that we learned from the survey responses were that nearly 90% of patients and 100% of caregivers reported either very good or some understanding of type 2 diabetes. But despite this, nearly 20% of patients and 22% of caregivers were either unsure of the recommended frequency of office visits or reported office visits that should occur every 6 to 12 months. We also learned through Pareto analysis that both patients and caregivers demonstrated a unique and limited awareness of complication monitoring for pediatric type 2 diabetes. In the patient population, this acknowledgement was limited to hemoglobin A1C, weight management, and blood pressure control. In contrast, caregivers demonstrated a broader awareness of complications needing to be monitored, which does suggest a better understanding of the long-term systemic complications associated with type 2 diabetes. Both patients and caregivers demonstrated in alignment relatively the factors that improve diabetes control. And so primarily those being physical activity, blood glucose monitoring, and medication adherence. But despite this, upwards of 20% of patients and their caregivers either answered incorrectly or were unsure of which factors should be monitored long term. And lastly, unfortunately, less than 100% of both patients and caregivers demonstrated awareness or recognition that things such as sweet treats or carbohydrates could affect blood glucose. Taking those key learnings from the surveys, we acknowledged that despite there being self-reports of generally good understanding of type 2 diabetes, there are clear discrepancies between patient and caregiver perception of knowledge and actual knowledge. And so this led us to the development of our SMART aim, which was to identify gaps in health literacy among our patients with type 2 diabetes within our clinic and improve those factors that can impact health literacy by 10% from baseline by June of next year. So our team sat down and really wanted to create a depiction of the very complex interconnection of factors that can impact type 2 diabetes. And what we found was that health literacy plays a central role in this, in not only the management of type 2 diabetes, but also on the quality of life of these patients and their families. And so we created a fishbone diagram to really understand and look at which factors can really impact that low health literacy. And we identified things such as socioeconomic factors, education gaps, cultural differences, etc. And identifying these factors really helped us to fine-tune our interventions and helped us to target our future PDSA cycles. So in creating our key driver diagram, we established that our overall global aim was to improve the quality of life of our pediatric patients. But keeping in mind our SMART aim, we were able to identify specific key drivers that can impact health literacy in youth with type 2 diabetes, including assessment of health literacy, education, efficient use of technology, patient and caregiver engagement, and staff training. And we created interventions tailored to each key driver. And you can see with the color coding legend to the right, the status of each of those interventions. And so we still have much work to be done. Our current PDSA cycle, we decided to focus on standardizing the education delivered to patients. And so we started by shadowing in our wellness clinic. Our wellness clinic manages many of our patients with prediabetes or are currently being evaluated for type 2 diabetes. And so often this is the first touch point for counseling for these patients. And key learnings that we took away from that included that generally, the information that was relayed to patients was very reasonable, very appropriate, but the depth of that knowledge and that counseling had very wide variation from patient to patient. These visits focused on setting very simple, tangible goals, and the language is generally kept very simple, which was very helpful and patients were receptive to. The latter part of this cycle, we are planning on shadowing and observing in the outpatient and inpatient education for new onset type 2 diabetes patients, primarily to assess key differences in that education. And so we look forward to learning those things. So through this very early work of this project, there were several key learnings that we had. First, that health literacy plays a critical role in successful management of pediatric type 2 diabetes, and there are clear gaps that exist, particularly regarding key monitoring metrics and nutrition. Age-appropriate targeted education for not only patients but their caregivers is warranted to optimize management and quality of life. And perhaps most importantly, there's a significant need for a validated health literacy survey in the pediatric type 2 diabetes population. Thank you for your time. Happy to take any questions.
Was it on paper? Was it a QR code? How did you administer that?
It was on paper. Yes. It's a wonderful question. Just English, although language barrier is on our list of potential interventions to try and improve the education provided to families. But yes, English. Yes.
Great talk in a very clearly much needed area. So thank you for that. One quick question I had is, when do you assess for health literacy? And is it just at one time point, or do you do it repeatedly?
So assessing for health literacy is novel within our type 2 population. For the purposes of this project, we decided to target patients who have had a diagnosis of type 2 diabetes for at least 2 years. And that is mostly to understand retention, and then through our key drivers and interventions, potentially targeting all the way back to diagnosis, how we can impact health literacy later on. Thank you.
I had a question about maybe your survey, or if you could just speak to this broadly, the difference between health literacy versus like disease specific education, because I sort of think of those things sort of separately, and I wonder how that came up in creating your survey and how that played in.
We wanted to start broad. And so I think when we defined health literacy, we really wanted to understand what is the general understanding and knowledge of our patients for their disease, what are the subsequent comorbidities that have been developed. So sort of the entire process. And so when we developed this survey to assess their literacy, we really were looking at what can we do to improve their knowledge and their retention so that ultimately we're decreasing their comorbidities later in life. I'm not sure if that answers your question. Sorry.
Yeah, it does. Can I ask a follow-up question?
No, please.
And I saw on, I think I saw on your fishbone, like one of the items, I think of health literacy, like, do you know where and how to get your prescriptions? Like if you need a refill, what steps do you take? Like kind of the general, like how does the healthcare system work? Like what is an appeal? What is your health insurance? What's a copay? What, like those things. I'm curious, these are topics we've been thinking about educating in our general, like our whole diabetes population. I'm curious if those are aspects that you've addressed, or is it mostly like, again, disease specific education?
It's mostly disease specific education. Your point is very well taken. We haven't even broached that, but there's surely room for improvement there.
Oh, we have a question on Zoom.
Sure.
From Trudy. So was there any assessment of level of education or capacity to do math or better model education efforts?
There was for the caregivers. We did assess education level. I didn't include that data in the slides, but we did not assess ability to do math, but we did assess their education level. So we do have that data.
I'm curious if you were able to see if there was any link whether the parents themselves had diabetes.
Oh, that's a wonderful question. No, we didn't even look at that, but potentially for future iterations, yes. because you would think the education delivered to adults is likely different to pediatrics, but maybe not. Thank you.